development. And in 2013, he was awarded the prestigious Gardner Global Health Award for global scientific contributions to the field of STD, sexually transmitted diseases, and their effective treatment and prevention. Dr. Holmes is the principal investigator for the University of Washington Fred Hutch Center for AIDS Research, and is also principal investigator for the UW-UCSF International Training Education Health Center for Health, ITEC, one of the largest HIV/AIDS training programs in the world. He also directs the UW Center for AIDS and STD at WHO Collaborative Center. He has participated in research on STIs for 15 years, with previous or current work in Africa, Latin America, Southeast Asia, and the Western Pacific. He has authored over 750 publications, including 546 peer-reviewed publications, and has edited 30 books, monographs, and journal supplements. He has trained and mentored over 130 scientists involved in STI, HIV research and care. And I have heard this quote that he fathered the field, and his children and grandchildren are now leaders in their field. And because I am humbled to be considered one of his academic children, I wanted to just mention some of the unique aspects of being a mentee of Dr. Holmes for the 4 years I was lucky to do so. And I'm doing this because there's a toast and roast for you that I missed because I'm not very good at sending these things. I thought I would share them with some of you. First, Dr. Holmes taught me to write a review as if you're signing your name to it. Probably don't remember telling you these things. But that is something that I think embodies personal conduct and professional graciousness that is rare sometimes these days now in our field, but that I was taught. He also, as part of that, taught me or tried to teach me when to know what to talk about. And I remember on a ferry ride to the IB conference, him saying, you don't have to use that word putt buddies, which was part of my paper. He also taught me about ownership over ideas. And this is probably one of the most powerful lessons. When I was a little fisher who thought, I'm still a little fisher, who thought I had the most incredible groundbreaking idea, which I don't remember what it was. And I think someone else had taken it and was running with it. He told me to just let it go. And to not worry about it. That's what's important, is that you're someone that has ideas, and that if you have a good idea, you'll have another good idea. And that's something I try to impart on my fellows as well, and students, that's one of the greatest gifts, is having an idea, not owning the idea. So he also taught me the value of the walk for the cookie, which I can't remember how many meetings I went in as an earnest fellow, just can't wait to talk over this paper or this idea or this proposal, and King would say, let's go for a walk and get a cookie. And at the time I didn't understand what that was about, but I think now it has taught me that what he was trying to teach me was to take a deep breath, and that sometimes you need to take a little space from what you're working on, and that that's the most important thing you can do. And finally, he really branched successfully interdisciplinary collaboration. I think no one else has done it the way Dr. Holmes did. He made me a fellow in an STD program when I didn't know what a fellow was, as to do a PhD. And he brought me into the room, and I'll never forget this, in the hospital, of a man with syphilis and HIV, and said, you need to see this, because you need to understand who patients are and not just see them on paper. And I think that it's rare that we actually have people willing to make that connection at this point. I also have to thank him for sending me my first brothel. And as part of that, he makes these connections between medicine and public health personal and professional, and that's a legacy he leaves not just for me, but for the field. And so, it is my honor to introduce Dr. Holmes.
Thank you, Pamina. You are one of my gifts to me when you were my fellow. So thank you all for coming. And when I was first invited to give grand rounds, I thought it was going to be a medical grand rounds. That's the only kind of grand rounds I've ever been to. How many of you are actually clinicians? Raise your hand. So it looks like maybe half or so. And so I had all written grand rounds. I had about 10 cases, and it was going to be a very case-oriented presentation. And then I thought maybe I should keep a few of these, because for those of you who haven't been clinicians, it may give you a little sense of what the clinical problems we are dealing with that relate to sexually transmitted diseases in patients with or without HIV. So I have kind of a mixed presentation today based upon that. And let's see. I'm guessing, there we go. So the first question is, why should you care that there are STDs in people with HIV? You don't work in an STD clinic, and many people working on STDs think that they have more important things to deal with than other sexually transmitted infections. So why should people be interested in this? And I want to give you an orientation to my talk. First, I want to give you an overview of what I'll tell you over and over again during the entire presentation. So this just came out in the New Yorker last week, and I couldn't leave it without sharing it. This was published last month in one of Seattle's favorite magazines, and I read it every month, and I picked it up, and this is what was at the bottom: The Case for PrEP, or How I Learned to Stop Worrying and Love HIV-Positive Guys, by a colleague I know. And it was an interesting article, interesting to me because some of my colleagues were ones who led studies of pre-exposure prophylaxis with antiretrovirals to prevent acquisition of HIV. And in his article, he says, talking about his conversation with his doctor about how many patients with HIV were not using condoms anymore. He said, "Many of the patients with whom I work have been using condoms more since going on PrEP. Part of their strategy has also been more open discussion with partners about testing and treatment, status, viral load, etc. And most of these patients were not using condoms at all before." And the author's, Evan's own comments were, "I had not once in my entire life had condomless sex. And I care enough about Scott, who is someone in the story he had met 2 months before, that it would be emotionally significant, but not like some sort of ceremonial loss of virginity. So we did it, and it was fantastic. But I'm still going to use condoms for casual sex." So how might this new phase of condomless sex that we are beginning to see work out today for this man and for the population as a whole? And these cases that I'm going to present to you now will give you a little sense of that. So the first patient I want to present is a computer programmer with seizures. He presented with seizures in focal neurological science. He was 36, and he had a convulsion at home. And this was after a week where he'd had progressive numbness in his right leg and uncontrollable shaking in the leg, and then he was hospitalized. And his social history was relevant for that he had sex with other men. And he was, in general exam, he was alert, young, fit, African-American man. His neurological exam showed that he had slight weakness and sensation loss in his right leg. His lab studies, he had an elevated white blood cell count, and his hematocrit was a little low. And then he had an MRI of his brain. And the brain MRI was quite abnormal. And just to show you here, he had marked edema in the area of his brain that was the sensory motor area of his parenchyma of the brain. And also quite important, and for those of you who really know the field, this might mean something to you, but his gadolinium scan showed that on the surface of the brain, on this so-called dura, and just under the dura, he had this enhancement with the MRI that was quite abnormal and characteristic of what this guy turned out to have. So he was started on an anticonvulsant drug and on steroids, and he improved for a couple days in the hospital. We sent him home for Christmas, and he was planned for readmission for a brain biopsy to figure out what these abnormalities were going to be. And so additional labs came back while he was at home, and by the time he returned, we knew that he was HIV positive. He had a reduced CD4 count. His viral load was high, 52,000. He didn't have toxoplasmosis, and his cerebrospinal fluid that had been done while I was in the hospital didn't show a lot. He didn't have a lot of elevated red blood cells. Glucose and protein are reported here. His cryptococcal antigen was negative for that fungus. negative for other viruses. And the centrifuge to look for cells in the CSF was pretty normal too. But, so what's the diagnosis here? And I won't force anybody in the audience to respond. I'll just go ahead here and say that the infectious disease fellow got the history that he'd been treated for secondary syphilis 4 months earlier with the standard dose of penicillin. And his VDRL was reactive. This is a test for syphilis at a very high titer. But his spinal fluid, CSF was negative. So this is a guy who had syphilis involving his brain, clearly. And the pattern of the appearance on the dura like that is characteristic of a gamma, so-called tertiary syphilis, even though he hadn't had this for a long time. So he received 14 days of intravenous penicillin, and his steroids were tapered off, and his numbness and weakness of his right leg completely resolved. So the relevance of this is, he came back and his studies of the brain were completely normal by MRI at that point. So when we have people with HIV who are having or who are at risk for HIV having unprotected sex, and they show up with syphilis, and I'll show you what's happening with syphilis nationally in a minute, we sort of write it off and say, oh well, it's just syphilis, it's easy to cure. This was a guy who had been treated with standard doses for syphilis. He wasn't cured, and he went on to develop what was potentially a life-threatening infection of his brain with syphilis. And this is not a rare event to have manifestations of neurosyphilis in people with HIV. This is what's happening with syphilis. This is just in Seattle-King County, but this was 1987. We began making a graph of this, showing that there had been a steady increase in syphilis in our community. And then it began, and the cases then the cases began to drop off with the advent of HIV/AIDS until 1996, when we submitted a paper to a journal to be published. We called it The Elimination of Syphilis in Seattle-King County. And then look what happened. They started coming back. Fortunately, they sent it back for some changes, and not undaunted, we said elimination and reintroduction of primary and secondary syphilis. And they published it. But what happened in 1996 that might have accounted for this coming back? Any thoughts? What? I think I'm hearing ART was started and HART. And actually it was in 1996 at the Vancouver meeting, the International AIDS Society, that for the first time we celebrated. I came home from that meeting and went on our annual AIDS walk, and I ran by a newsstand where there was an article on it, a journal like The Stranger, and I had a picture of one of my friends on the cover who was a gay man who was paid by the CDC to promote safer sex, and his comment was, now we have treatment for HIV, we don't have to worry about condoms anymore. Well, this is what we began to see back then, and this is what we've seen since then, and it's continuing through today. And you can see here was the little blip we had that I showed you in an earlier slide. We now have more early syphilis in Seattle-King County than we've ever had in recorded history. And this is happening throughout the country. This shows that these are predominantly in MSM with very little heterosexual syphilis anymore. And then we estimated the number of people in the county, we pretty well know, who have HIV. And you can see that almost all of this early syphilis is occurring in MSM who have HIV. And it's really concentrated in this group of men. And so why is that, and what are the implications of that? Now I'm going to shift on from that case, indicating a phenomenon that's national, that we are seeing increasing STDs, gonorrhea, syphilis, others, involving MSM, and some of them are quite dangerous STDs. Now I'm going to give you another case, and this we'll call the man who kept his colon. He was a 25-year-old bisexual man hospitalized with 13-day history of anal rectal pain rectal bleeding, rectal discharge, fever, low abdominal pain. He was having frequent stools but not diarrhea. Tenesmus is pain in the area of the anus. His temperature was elevated. He has his left lower quadrant where the distal colon and rectum are was tender, and his anal sphincter on finger exam was very tender. He had a rectal discharge, lots of polymorphonuclear leukocytes in his rectal discharge. His peripheral white count and sed rate were elevated. And on sigmoidoscopy, he had a lot of mucopus. It was bloody. It was very easily induced to bleed with a swab, all the way up to but not above 12 centimeters. So it was limited to the distal rectum. Didn't go up higher into the colon. And he had 3 ulcers at this site as well. So what could this be? And we'll tell you. Here were his diagnostic tests. His rectal cultures for the usual rectal or intestinal pathogens were negative. Gonorrhea and herpes were negative, no parasites. Rectal biopsy, I'll show you a picture, showed lots of inflammation and infiltrates with lymphocytes and plasma cells and polymorphs. He had abscesses in his crypts, lots of granulomas in giant cells. So the interpretation was that he had what's called Crohn's disease. And he was started on rectal steroid enemas and sent home. Crohn's disease is a chronic disease that can lead to major problems with the colon. And this is a picture of a transmucosal biopsy of such a patient, showing how much extensive inflammation there is that goes throughout the entire mucosa of the colon, of the rectum. This was this guy's biopsy, showing that he had what you call granulomata with giant cells, as you can see here. This is typical of Crohn's disease, which was why he was sent out with this. So meanwhile, I had a new infectious disease fellow named Tom Quinn who came in and to let him know he was going to be working on this syndrome called the gay bowel syndrome, I brought him home and gave him a martini. And Ned Hook, who was the chief resident, called up. It just happened that one of our first fellows came in with this syndrome. And we had a little kit for Tom to take in with him to Harborview. So he went in, and lo and behold, on the tests he did, chlamydia trachomatis was isolated from the rectal mucosa. And it was typed as a lymphogranuloma venereum strain of chlamydia, which causes pretty severe disease when it gets into the rectum. His antibody titer to chlamydia was very high, which is also consistent with lymphogranuloma venereum. And so the patient was called back. He was still having lots of symptoms. He was started on doxycycline, and he became completely asymptomatic. And he was brought back 6 months later and was completely normal. So you could say this is just another chlamydial infection if you don't really pay attention to what's going on with these patients. But when you see real patients, this is the sort of thing that happens. And if he had not been called back, had not been tested for chlamydia, for LGV, this could have gone on to lead to a hole in the rectum and a rectal fistula, stricture where you had to dilate or take the colon out. And so he fortunately was not having to go through that because he was diagnosed and treated. So proctitis is what you call inflammation limited to the rectum. And the causes are gonorrhea, chlamydia, including LGV, syphilis, and herpes. And herpes proctitis in particular can be quite severe in such patients. And currently today, we have a widespread ongoing outbreak of lymphogranuloma venereum proctitis, which went away for 20 years, but it's now back in Europe, in the UK, some cases in North America, and Australia. And it's strongly associated with HIV, hepatitis C, which we never used to think of as sexually transmitted, but do now, Shigella, and Salmonella. And this is a recent paper, came out last year, showing the epidemic curve of LGV in, I think this was from the UK. And here they stopped doing enhanced surveillance, but you can see when they started surveillance, it just has kept going up. I think we're not seeing a lot of this in the States yet because we've stopped looking for it, whereas they're looking for it in the Netherlands and in the UK, and they're seeing a lot of it. And we've just stopped doing it in our clinic, where we were the leading people detecting these cases in the past. There was a historical study done on this by Ann Rompalo, Walt Stam, and others. It was historical in the sense it was the first published randomized trial of syndromic management of STDs, where you would treat before you got the results of tests back. And so treating immediately versus testing and then waiting for the diagnostic test to be coming back before you treat based on what the results are. And so what they tried was syndromic treatment right when the patient first came in for gonorrhea and chlamydia with ceftriaxone, misspelled, and doxycycline. And then this led to faster resolution of proctitis and faster elimination of the causative pathogens than when you waited to treat based on test results. They also found, however, that 25% of these people had rectal herpes, didn't respond to the treatment for gonorrhea and chlamydia, and so therefore they would, and I always would, consider and give syndromic treatment for herpes while the tests for herpes are pending, even if they don't have the typical manifestations. And you always have to rule out syphilis in patients with this presentation. So that's an example of proctitis. Now here's another case of a young man who came in with hepatitis. He had rapidly progressive hepatitis, and he had a life-saving examination from somebody who Jeff Klausner would know as one of our fellows when Jeff was there. And this was a 19-year-old man who, the first time he had sex was with a casual sex female partner, and he developed severe asthma. Tough way to start your sexual life. And he was seen in the emergency room and given prednisone and sent home. And over the next week, he developed pain in his right upper quadrant where your liver is, and nausea, and he was hospitalized. And the exam then showed that he had tenderness in his right upper quadrant. He had a temperature. He had very high abnormal liver function tests, some of them. Bilirubin was elevated. His tests for hepatitis A, B, and C were negative, and he was rapidly deteriorating. It looked like he was going to die, and transferred from Harborview to the UW Medical Center. And Matt Golden saw him as the infectious disease consultant, and he actually examined the penis, which often doesn't get done in people with hepatitis. And he found multiple shallow, painful, tender ulcers without much succinate, and the culture yielded herpes type 2, and his Western blot antibody for herpes was negative, which is typical of primary herpes. The antibody hasn't yet developed. So he was treated with intravenous acyclovir, and he rapidly improved and didn't die. And so you could say, oh, well, it's just another case of herpes. On the other hand, this is what can happen with herpes. Fulminant herpes hepatitis is particularly common in immunosuppressed patients like those with HIV, which wasn't this patient, but is particularly a problem with that type of patient. This is what's been happening with genital herpes. We first started seeing genital herpes in the States in the early 60s. I mean, I won't say it was never seen, but it was hardly ever recognized. And this is what's seen in recent years. It's more visits to physicians plus better recognition by physicians. But we're seeing a lot of it. And here are two other cases that were reported from the University of Washington. Here's one from Jeannie Marazzo. This was a examination of the liver showing papules on the liver caused by herpes. And here was a patient, this was reported by, I've forgotten who, Anna Wald, who's a herpes specialist from the UW, and Connie Kellen. And this was a patient who actually came in with acyclovir-resistant fulminant herpes, hepatitis, and went on and died at day 65. So this is a potentially fatal disease, not only in pregnant women and their babies, but in adults, particularly those who are immunosuppressed. It's not always just another case of herpes that you take acyclovir for. So actually, most people prefer condoms over herpes. And condoms is part of the message today here. And actually, acyclovir works too if you take it to prevent herpes. And this was a nice cartoon. Anna Wald and Larry Corey showed that if you took acyclovir, you reduced the frequency of transmission to the partner significantly. So this was a guy who actually called me. He was 30, a lawyer, and or his clinician called me, and the patient, the lawyer, said that he had a recent casual partner, and he also had a wife. And the casual partner just had a pap smear showing dysplasia, and he'd read that dysplasia could be a sexually transmitted infection, and he wanted to know what he could do to prevent infection of his wife. So that's an interesting call. And this is what happens at the University of Washington when you become sexually active. Rachel Weiner did this when she was a fellow, and you can see the proportion of young women who had never had sex. At the time they had first sex, they came right in, so they just had sex, and they got enrolled in this study, and they were followed to see whether they would develop human papillomavirus infection. And you can see that by the time you get your diploma at the University of Washington, more than half of you get human papillomavirus infection of the genital tract as well. So this is a very common syndrome. It's common in males as well as in females. And there are 100 HPV types out there, more than 100. Everyone in this room has some form of HPV. And of the men and women in this room, probably, I don't know, but 60, 70, 80% or more have had genital HPV. There are 12 of these types that are cancer causing, and so many people here are at risk of the genital or anal cancers. This is what HPV infection, when it causes dysplasia. This is normal. This is an abnormal cervix. This is typical of dysplasia if you're looking at it grossly by magnification. Papillomavirus infection of the cervix is the largest cause of life years lost to cancer in the developing world. Type 16 and 18 cause about 70% of cervical cancer worldwide, and 70% are covered by the 2 available HPV vaccines. And the new 9-valent vaccine, which is still under review, when it becomes available, should prevent about 90% of these cancers. So, since 2011 for girls and 2009 for girls, I think. I may have this down. This is what the vaccine looks like when you take together the virus-like particles made by the L1 gene. You get something that looks like this. And in the MMWR this July, it was found in a national survey that only 53% of girls and 35.6% of boys in the U.S. had received even 1 dose of HPV vaccine. Recommended is 3 doses. And if you're older than young girls and boys, fewer of you will have been around going through school at the ages when this vaccine is given. So most of the people in this room probably have not had HPV vaccine. And the parents reported that clinician recommendation for HPV vaccine was significantly more for the parents of girls, around 64%, than for boys, parents of boys. It had increased over a couple of years to 41.6%. But that's still way too low. So for this man and his wife, it was very unlikely if he had called me today that either he or his wife, he at 30 years, his wife maybe similar, had ever received human papillomavirus vaccine. So why should we give a HPV vaccine to kids? It's recommended for girls at age 9 to 11, and boys. And why not wait until they get to be, let's say, 16, when they can weigh in on the decision themselves? Every year the Youth Risk Behavior Survey gets done, or I don't know if it's every year, but it's frequently. And here's the percentage of high school students who report ever having had sex. For grade 9, it was 30%. Those of you who are parents here who have kids of this age, I know you're going to groan when you see these figures, but 41% for grade 10, 54% for grade 11, and 64% for grade 12. So that's one of the reasons you don't want to wait to give this till they're 16. And then there was a big concern that if you gave it early, you're going to increase the frequency that kids would have sex. There's now been an analysis of this, and early HPV vaccine doesn't increase early onset of sex. And I only learned this recently, that the antibody response to the vaccine is significantly greater at ages 9 to 11 than it is for ages 12 to 15 or 16 to 26. another reason to give it early. So if you have boys or girls who are before, ages 26 for girls, you should get it to them, and for the boys probably too. So the HPV vaccine guidelines are for females 9 to 26, that came out in 2006, and for all males 9 to 21, or to 26 if they're HIV positive, came out in 2011. Here's another interesting study. Females prefer male partners who have had HPV vaccine. And that is 63% in this study strongly preferred a vaccinated man. And 13% only didn't care. And if you don't believe me, here's the reference. Just came out recently. So, another incentive for your sons to get their vaccine. Now, why should young males get the vaccine? I mean, they don't get cervical cancer. Well, one fact is that oropharyngeal HPV cancers will outnumber cervical cancers in this country during this decade. So that's only 6 more years. So who gets oropharyngeal cancers? They're 4 times more common, the HPV-related ones, in males than in females. And the N. Haynes study, National Health and Nutrition Exam Survey, shows that oral HPV shedding is significantly more common in males than in females. I don't know why, but I suspect the risk of males acquiring HPV is greater by oral sex than the risk of females acquiring it, at least for heterosexuals. Another interesting fact coming out recently is that the Glaxo vaccine cervix trial in Costa Rica with 4 years of follow-up showed by swabbing in the throat that 15 cases of HPV 16 or 18 in the control group, but only 1 in the vaccine group. So there is data that you actually decrease oropharyngeal HPV in that observation. No plans I know of underway to actually study the impact on oropharyngeal cancer per se. Anal cancers predominate in males, as you, I'm sure, all know. So should we give HPV vaccine to males? How many think we should give HPV vaccine to males? Okay. How many don't? Okay, it's unanimous. And there are good reasons for that. For this guy who called, his doctor who called me, it's too late for the vaccine, I think. And I don't know what to tell him. What I said is there is a risk you could transmit it. We didn't have a vaccine then. And your wife should be getting checked by pap smear, and gave him the current pap smear guidelines. But the vaccine will prevent the need for that, or at least reduce it. So nowadays you should also realize that we don't only prevent HPV by vaccine. It's just like HIV. We have combination prevention. So the vaccines now, the 9-valent we hope out fairly soon. But voluntary male medical circumcision is associated with a 30% drop in risk of HPV among men. And it also reduces the risk of these other infections, as well as BV and trichomonas in the female partners in more than one study. Condom use decreases the risk of catching HPV by about 70%, another Rachel Weiner study. It also decreases the risk of virtually all other STDs except for crab lice. So keep that in mind. But don't worry about the crab lice, because this is what's happening with the crab lice. This is astounding to me, and that is from the study from England. The prevalence of removal of the hair from their patients coming into an STD clinic has risen from about 30+% to almost 90% over this 10-year period. I was astounded by that. I first couldn't believe males were doing it as well as females. This is both genders, and people just tell me I'm an old fart and I'm not keeping up with what's really happening in the world. But what's happening with the incidence of pubic lice infections or infestations is that it's almost disappeared. There was a TV program, the Jon Stewart Show, declaring crab lice as an endangered species, and you can actually buy a kit. A little bag that has a picture of a crab louse on it saying, "Save the crab lice," and you can carry that around. So condoms don't prevent that, but don't worry about it, as long as you shave your hair. So this is sort of an introduction now to tell you what we're looking towards with increasing use of ART, which is very important, increasing use of PrEP, which has great potential, I think. And that is that there are at least 8 potentially fatal viral STIs that are not prevented by PrEP. And they're shown here. So they include human papillomavirus, cancers of men, cancers of women, HIV, particularly those who are older and weren't vaccinated, HIV, hepatitis C virus, herpes simplex virus, HTLV, human herpes virus type 8, Epstein-Barr virus, particularly a problem in HIV-infected individuals, and hepatitis B virus. These are all potentially fatal, causing malignancies, chronic diseases, and so on. People who are switching to PrEP and considering not using condoms really need to know this. So PrEP doesn't prevent HPV, Hep C, Hep B, HSV, HTLV, HHV8, or EBV. What percentage of U.S. adults have had the hepatitis A and B vaccines? All of them are sexually transmitted. I didn't mention A as a potentially fatal one. It isn't often. This paper by Matthews in PLOS One found in a survey that 64.5% of HIV negative or untested MSM in the U.S. reported not having been vaccinated against Hep B. And if they were born before we started using Hep B vaccine, which I think was about 91, they haven't been vaccinated at all. So these are our patients who we're seeing in the clinics or who are at risk. What about HHV8? We don't hear much about that. Among Peruvian MSM, this paper by Juan Guinera showed that HHV8 was found in 70% of HIV positive MSM and 27% of HIV negative, so associated with HIV, and also significantly associated with anal receptive sex, or STAs, in the past year. There is debate about how this is most commonly transmitted. We think mainly by saliva, but these are data that suggest it may be related to sexual contact as well. Pamela, what does HHV8 cause?
You warned me you were going to ask me.
Who knows what HHV8 causes?
Come on, fuck Jeff.
What does it cause?
sarcoma.
All right, good. Is that associated with HIV? All right. So we want to put all this in your mind. And then we don't often think of CMV either as sexually transmitted disease, which it clearly is. There's lots of data that's sexually transmitted. And also, this was a recent study from a different person showing the prevalence of CMV in semen of men with HIV. And 50% of the men with HIV had CMV in their semen. And also EBV was in the semen. And you can see that among 100 men with plasma HIV viral loads, less than 50 copies per ml, the only predictor of whether they had seminal HIV shedding, and these with low viral loads, was the presence of CMV in the semen. So it may be a risk factor. More is going to be done on that. And there's another, who knows, there's another potentially fatal sexually transmitted infection. Anybody recognize this one? Ebola, right. It's amazing. You don't all jump up and down and say Ebola. It's been in the paper so often. Men who are recovered from Ebola shed Ebola in the semen for up to 3 months. The standard protocol for treatment and follow-up of these men is to put them, to make them, have them use condoms for 3 months. There are some household data that are in the literature, but not very persuasive, that the probability of finding Ebola in a household member is much greater for a spouse, a conjugal partner, than for other members of the household. So I don't think this is the main thing we worry about with Ebola, but it's another one. So here are 5 questions for the future. What will be the impact of scaled up ART and PrEP on sexual behavior and on condom use? And parenthetically, what can we do about it? And I've shown you what was just published in a magazine that's read all across our city. Will other epidemics of potentially fatal STIs accelerate even further in populations at high risk? For example, causing more anal cancers, liver disease, including liver cancer, lymphoma, and so on. Will this astounding resurgence of STIs in the United States and globally again increase transmission of HIV, as there was so much evidence for before before now? Will increasing unprotected sex lead to the emergence of new STIs, analogous to the emergence of HIV as a new STI in 1980, sort of culminating the steady, rapid increase in STDs leading to the gay bowel syndrome in 1979 or so? Or will there be emergence of new variants of STIs or more virulent variants of HIV? When rates of transmission go up, sometimes virulence increases, sometimes it doesn't. Will increasing unprotected sex during scaled-up ART and PrEP accelerate antiretroviral resistance in individuals and in populations? And my take on this is, how could it not cause that? So when I first started working back in Seattle, I wrote this book with Jennifer Weir. We called it How to Have Intercourse Without Getting Screwed. It was translated into Spanish, and they got the right translation, A Current Guide to Sexual Emancipation. It seemed to us at that time that all we needed to do was have good diagnostics and treatments for 6 or 7 STDs, and that we could take care of it. But I don't feel that way anymore. It isn't the real world. We're mixing microbiota from the mouth, the pharynx, the skin, the genitalia, the intestine. We're doing it rapidly. Populations are becoming more dense. Populations are more mobile. Antimicrobials are being thrown around without good regulation, wrong doses, and things are going to keep getting worse. We have to respond more responsibly to this. But when things were getting much worse in 1979, David Ostro invited me to go give a talk to for an issue of the Journal of Homosexuality that was published then. I don't know if it still is. And he asked me if I'd talk about STDs. And what I basically said, this is when Tom Quinn saw that case of LGV proctitis, and 50% of the patients coming into our STD clinic were men who had this syndrome of proctitis, proctocolitis, or enteritis, 12 different pathogens implicated. I concluded, when I went back and saw what he said, that I'd suggested that behavioral and sociological factors may well be the most important areas of research and modification in the battle against these growing lists of STIs. Well, I think it's worse now than it was then, and I'm feeling the same way now that I felt then, only we have more tools and we have more responsibilities. Today there are more than 35 STIs. They're part of the routine differential diagnosis of many, many clinical syndromes in people with HIV and in people without HIV. Everyone with HIV has other STIs. There are major implications of emerging or re-emerging STIs in terms of increasing HIV risk in populations as well as in individual patients. Several STIs facilitate HIV transmission, and several STIs other than HIV, particularly the viral STIs, can be fatal. And yet many of our clinics don't address these viral STIs. So why should we care about this? As sentinel indicators of HIV risk, STIs should prompt HIV testing of persons with STIs every time we see somebody who hasn't already been shown to be infected with HIV, and their partners. Integrated STI and HIV services really improve the HIV treatment cascade by increasing the diagnosis of HIV. When you see an STD patient and you test that patient and their partner, you're finding lots more in a very cost-effective way people who have HIV. In Seattle, for example, and in the UK, it's estimated that 70% of people with HIV have a suppressed viral load. CDC estimates are still ballpark of 25%. I don't know if it's that or higher. I'd be interested in other people's thoughts. In low-income countries, it's not certainly any higher than in the States and probably lower. In Seattle, our HIV programs and our STD programs say that the Seattle clinics, STD clinics, refer 30% of people entering HIV care. They would have been missed, but because they come in with syphilis or gonorrhea, and that's so much increased in HIV-infected individuals, that we're just picking many cases up that we wouldn't otherwise. So STI services are important in HIV detection and prevention. And unfortunately, STI clinics are really an endangered species. They haven't learned how to bill. They're closing down all around the country, although that closing has slowed a bit in the last year or two. So my first conclusion is that for clinicians and for public health workers and researchers involved in HIV care and prevention, don't limit your attention, as most of us do, to HIV care and for the non-infectious comorbidities, like mental health, metabolic difficulties, cardiovascular diseases. And and for individuals, our patients and those in the population, and key populations at increased risk, the message should be that to protect yourself from sexually acquiring HIV and other potentially fatal viral STIs that many of your sex partners have, to protect, and you protect yourself with the not just PrEP, and to protect your partners from any of the serious viral STDs you already have, protect yourself, protect them with condoms and other approaches, and to protect yourself from catching antiretroviral resistant HIV from an HIV-infected partner. Use condoms, get vaccinated early, for example, with what we've got, HPV, HBV, and HAV. Consider PrEP as part of combination prevention. And that's the way it was in the clinical trials, which promoted and provided condoms at every visit where PrEP was provided. Patient would be seen by the doctor, use condoms, by the nurse, use condoms, by the pharmacist, use condoms, given condoms. That's the way it was shown to be as effective as it was. And don't depend on serosorting or seropositioning alone, which carries a huge risk of other STIs, many of which can themselves be fatal. So on that ebullient note, thank you. So I would love to have a few questions or comments, critiques. Yes?
The CDC currently doesn't recommend rectal testing for chlamydia, and I'm wondering if you could comment on that or why that is for MSM that we're talking about.
Yeah, I wasn't aware of that. I think we have some papers coming out of Matt Golden and his colleagues showing the value of testing the throat for gonorrhea and the rectum for chlamydia. Now, I think if somebody is asymptomatic, the pressure is there less than for somebody who has symptoms of proctitis or proctocolitis, where I think we should not only be testing for chlamydia, but sending the specimens to be tested for LGV. There still are laboratories in the country that can do that, but they're lots fewer than they used to be. Maybe in the back there, yeah.
I wonder if you could speak to the potential increased risk of HIV transmission among virally suppressed HIV-positive patients with STDs or other general tract infections or inflammation.
So what's the risk of transmission in somebody who's got a suppressed blood viral load, plasma viral load, if they have other STIs? I think it's a really interesting question. I think that the surrogate is looking for amount shed in the semen. It's been shown that women with HIV or trichomonas are more likely to shed HIV in their vaginal fluid and to infect their partner. And that was done by Craig Cohen. I haven't seen that published yet, but it probably is by now. And the data I was presenting to you on the patients. This wasn't in his study. I don't know what he did in terms of adjusting for whether they were on antiretrovirals or not. But the study that I showed you about the CMV, that even for those who had viral loads less than 50, which we consider, pretty safe, there was semen shedding. So I suspect we'll be seeing more data on that. But it's a good question. Yes, hey, how are you?
We did a study recently of just a population tested all for STDs and found out that somewhere in the order of 70 or 80% of the individuals who had gonorrhea or chlamydia were asymptomatic. So I think two questions arise out of that. One is it transmissible if it's asymptomatic? And two, what do you recommend for reaching those populations?
In the past, we did studies of asymptomatic GC, quite a few of them, and although I would say it's most common when you call in a partner who hasn't yet been treated from somebody you've just seen, to see, for example, if the patient was a female, to see a male who says he has no symptoms, and you strip the urethra and there's florid mucopurulent discharge where they're just ignoring it or denying it. But we also saw plenty of patients who were asymptomatic and who shed it. So that's sort of personal clinical experience from what we've seen. I can't think of, maybe Jeff, you might have some thoughts on that. Any data from systematic looks at it?
Yeah, well, we find high concordance between asymptomatic infected individuals and their partners.
And certainly if the male is showing up with gonorrhea, the female is very often asymptomatic. And one of the things that really finally drove GC down, which was back in the mid-60s and later, was the invention of Thayer-Martin medium, where we first started screening women who were asymptomatic. And all of a sudden, GC rates began to plummet, probably because we started looking at women, not just symptomatic men.
With respect to the HPV vaccine, it's been mostly tested in people under 25 or 6, whatever it is. Is there a case for giving it to adults above 25? Is there evidence that it decreases the cancer-causing strains in adults who may have some other kind of HPV?
Yeah, I think these guidelines came out through committees, that were the, what do they call the ACIP, yeah. And they base their recommendations in part on cost effectiveness as well as efficacy. The trials were done in these younger women. Laura Kautsky, one of my fellows, did the study that was in the States with Merck vaccine, and Jorma Pavonen and Susan Garland led the one that was done in the UK. So I think it's rational that if somebody doesn't have a huge number of sex partners and hasn't had the vaccine, to go ahead and give it to them. I actually don't know what the insurance policies are on reimbursing for that. They may be, particularly the federal guidelines. I mean, it's funny that the STD clinics used to be vaccinating people for HPV and offering it. And in our STD clinic, all you had to do was say that you didn't have insurance, and then that your income was less than $46,000 per year, and they would give you the Merck vaccine free. Since the Affordable Care Act, nobody can claim they don't have insurance or that they couldn't have insurance. And we've gone from giving hundreds of vaccines per month to giving 3 or 4. And family planning clinics are the other, the recommended approach that we're trying to follow is getting primary care doctors seeing adolescents and children to give the vaccine, but they're, as you saw, not doing a very good job of it compared to the Tdap vaccines, and Minage, which are given at the same time. They get very high coverage for that. But the family planning clinics apparently have to have the consent of a parent for somebody under 18 to at least that they know about it and so on for the child to get it. So the family planners give out more HPV vaccine than the STD clinic, but not a lot. And then the other is the ones who do the social marketing is actually the pharmacies. You can go into Walgreens or Bartell's or someplace and get the vaccine. I don't know what regulations they may have about parental requirements, but they're the ones that are really promoting it because it's profitable. Yes.
It was a great talk.
Thank you.
And I almost wish it had been a medicine grand rounds, because I think a lot of your message about screening for sexually transmitted infections needs to be heard by a general medical audience. But I guess I would offer that PrEP is going to create an opportunity for us to bring high-risk men who have sex with men into care settings where they can get screened and treated for STIs. And it could have the opposite effect of actually bringing some of these things under control.
Well, I wanted to, and that's why I'm giving the talk, and I would be happy to give it to some of the clinicians as well. I think they will play a key role, but they'll be swimming against the current, I'm afraid. Jeff.
So, thanks, King. I want you to comment on circumcision. So as you know, American Academy of Pediatrics came out with a moderately in favor statement saying the benefits outweigh the risks. Now the CDC has a statement for infants, adolescent, and adult males saying that the benefits outweigh the risks and people should be informed of that. You cited data showing the significant protective effect against a variety of STDs. How important do you think that is circumcision as a STD control strategy?
So I think, first of all, for heterosexuals, the first 3 clinical trials of male circumcision for preventing HIV, when the first trial came out, John Cohen from Science Magazine called me up and said, "King, what do you think about this?" And I said that if this is confirmed in the next 2 trials, this is going to be like a single-dose vaccine that's effective for life and very cheap. And the efficacy was in the ballpark of 60%. With longer follow-up, it's more like 70%, although it's no longer randomized, and there may be some bias in that. Well, the next day after that was published in Science, I started getting emails, hate mails, for my wanting to destroy the sexual function of men. And one of them was from somebody who lived in Seattle. And so I looked his name up in the King County Medical Society list, and it would list me as a infectious disease specialist from the University of Washington. It listed him as a chairman of the Anti-Circumcision Society of Seattle, Washington. So there are crazy people who are opposed to this, first of all. So the next thing is that the data are good, and their efforts will they protect MSM? And Jorge Sanchez did some analyses in Peru that suggested that the risk might be lower in circumcised men than in uncircumcised men. Maybe you or Tom know more about that than I have followed up on, but he tried to put a proposal through to the PTN to get that funded, and it wasn't funded because the data aren't as clear as it has been for heterosexuals. And I think the fact that it is, and in terms of the health economists, the implementing agencies like CDC, PEPFAR, Gates Foundation have elected to go entirely with young adult and adolescent male circumcision. Even though the cost is greater and getting access to the men is more difficult at that age, and the morbidity may be greater. With the prepex, this is this method of basically putting a clamp on the foreskin that causes it to necrose and drop off. And there have been 60,000 of them done, and the report just came out that 3 of the men out of 60,000, 3 that they knew of, developed tetanus, and 2 of them died. So that's a low number, but raises the question of, okay, how do we deal with the prepex now? And the manufacturer immediately came out with a note that said, only do this on people who you know have had tetanus toxoid. But that's a tough thing to do in a developing world. So I'm not sure what the impact of that will be, but I mean, there are nuances, but male circumcision is good, and I want to say that I've had one. And so I know your son has, because I went there. Actually, I went to see Jeff's son having his circumcision, and the moral was somebody I knew who was a doc at Group Health, family practice doc, I think. I should go here. And so the way they do it is they put a drape across the knees of the doctor, and then they sink the baby into the dark recesses of the little hole in the cover, in the linen, and then he's reaching down where I couldn't see anything down there, and his hand is going like this, I think, as I'm watching him. And I thought, my God, Jeff, I hope your kid comes out all right. But it's, whatever your question was, it's good to do. Other questions? These are great questions. Yes?
Yeah, many in this room have been looking at your papers for decades, so it's nice to see you in the flesh. And you have this was perhaps a different kind of talk than some of us expected. It's very clinical and very useful. But could you give I'm going to ask a question that reflects on your broad reach. STD clinics and primary care clinics have a very interesting history always in terms of who goes where, et cetera. Can you give any comments about where we are today vis-a-vis 20 years ago, or is it pretty much the same?
Well, there has been a steady increase in the proportion of people getting treated for the usual STDs who go to primary care docs. And the proportion now who go to the traditional STD clinics is much smaller than it used to be. Furthermore, the traditional STD clinics are heavily focused on gonorrhea, chlamydia, trichomonas, and syphilis. And if you talk to the clinicians working there, they're terribly bored, because you say, how's it going? And they say, it's the same old, you know. Whereas there are all these other STDs that are there to be seen. Now, the one thing that the STD clinics do that the doctors don't do is they do partner notification, and they give the right medications because they know what the guidelines are, and they're well into that. And so I think the really important, the sad thing is the UK is beginning to break up its AIDS and STD clinics, which had been combined until now, because they saw how it was being done in the States. And they're trying to get the private sector to do more of the AIDS. But when you integrate them in ways that when somebody comes into the STD clinic, they and the patient, their partner, get tested for HIV. They get definitely referred into the HIV clinic, and the disease intervention specialists get them in there. And when they're lost to follow-up, the AIDS clinics pretty much do a fabulous job of getting them care. But when they're lost, it's the public health system that really knows how to go out and get them back and find out where they went. And furthermore, the AIDS clinics are beginning to do hepatitis, and the STD clinics are beginning to do PrEP, or are likely to begin to do more of it. So I think there's a real synergy between them, and that the idea of just one or just the other is, I think, very short-sighted. The other thing that's evolved is expedited partner therapy. And with making medication available to the partner through drugstores, underwritten by the health department, about 2/3 of the states in the US have approved that now. And it does decrease the rate of reinfection with gonorrhea by getting the partner tested. On the other hand, if it's MSM, I think it's an opportunity to, or somebody who's otherwise at high risk for HIV, it's really important to go test that patient for HIV. All right, great questions. Thank you so much.